We're now moving towards our fourth and last segment focused on vasculitis. We are honored to have Dr. Sarah Elaine Hahn, Head of Department of Rheumatology at Shalimar Hospital, and Dr. Tahira Parveen, Head of Department of Rheumatology, Liaquat National Hospital, Karachi, as the chairs for session 4 of the Paediatric Rheumatology course.
Our next keynote speaker is Dr. Sujata Sawhney, Senior Consultant Pediatric Rheumatologist at Sir Ganga Ram Hospital, New Delhi, India. Her talk, titled MSK Ultrasound, Role in Pediatric Rheumatic Diseases, will explore the applications of ultrasound, the diagnosis and management of pediatric rheumatic conditions. Unfortunately, she could not be here with us in person, but her lecture has been recorded online and will be played on screen for all the audience. And she will be ready for the Q&A online as well. Thank you.
Good evening, everybody. And at the very outset, I'd like to thank the Pakistan Rheumatology Association for this very kind invitation to join this prestigious meeting. And a grateful thanks to Dr. Sumaira for inviting me for this talk. I'm sorry it's virtual, but I hope that next time around I'll be available in Lahore. And so with those few words, I'd like to talk to you today about the role of ultrasound in the area of pediatric rheumatology. So pediatric rheumatology is very much a clinical specialty, and today we talk about point of care ultrasound, such that the use of ultrasound is just like a stethoscope in clinical medicine, and it's extremely important and is used in our day-to-day practice in my center. Once you begin to use the ultrasound, you can hone in on your clinical skills, and it gives you a great insight into exactly what is wrong with the child. So, for example, if I'm seeing a patient who has a swelling around the area of the wrist and I put a probe on that area, it's very interesting for me to see, is it the radiocarpal joint, the intercarpal joint, or indeed is it both, or is it also an accompanying inflammation of the tendon sheets in this area. So it gives you precise anatomical location. Yet, pediatric rheumatologists don't use this tool very often. Less than 1 in 2 use it in Europe, and that too they don't seem to do a huge amount of work with this skilled area. What is the reason for that? I think the reason for that, it's a very steep learning curve, and we'll come to some of the issues regarding the use of ultrasound in children. It's really great because it helps you to examine the joints more carefully. It does not require any sedation. It can be done multiple times for the same joint, and you could do multiple joints at one time in the same patient. And there are so many advantages of using the ultrasound. It gives you the anatomic location of the problem in the patient and defines the exact pathology. Additionally, you can use it to monitor the disease of the patient. There are 3 important issues as we begin to use the ultrasound for the evaluation of joints in children. One is the appearance of the cartilaginous epiphysis. Second is the ossification centers that are appearing in children. And third is a lot of physiologic vascularity that can sometimes be confused with inflammation. And like I said, we can pick up the exact pathology and the exact site of inflammation for these patients. When we are able to assess the Doppler signal carefully in these joints, we can understand that a positive Doppler signal, which is both within of the joint cavity and within of the synovial membrane, that is intra-articular and intrasynovial, is going to suggest active disease for these children. When we do the procedures, we can do it with a lot of confidence because we can inject the specific joint or the tendon sheet under direct visualization. Of course, the one issue with the ultrasound is that we cannot penetrate the bone, and therefore bone pathologies cannot be picked up in these patients. There are some challenges as you begin to learn the ultrasound. I think one very important challenge is that this is an operator-dependent procedure and that it requires a significant amount of learning. As you go forward, you are not able to visualize any bone pathology, like I said, And the technology plays a huge role. So the quality of the machine is also important. As pediatric rheumatologists, when we look at the joints of our little patients, we can see that there are several challenges. If I start with a pain on your right side, which is the involved enthesis here, when I look at this little child, is it the left, the right, or both the ankles? And then in this patient, if it is the left ankle, exactly where is the swelling? Is it in the joint or is it in the tendon sheath? So the clinical evaluation is not very precise, and as we use the ultrasound with more confidence, we are able to define the exact pathology. And this certainly has ramifications. So, for example, if I do the ultrasound of an ankle joint and I find only the main ankle or the tibiotalar is swollen, I might want to inject it. But if I find the main ankle is swollen, the midfeet joints are swollen, and that maybe the tendo Achilles is inflamed, then I'd rather run an HLA-B27 on the patient and think of a systemic therapy. So it has implications for the classification, for how you want to treat the child, how do you want to define remission, and then finally, do you think it's going to have a role in the future classification criteria which are defined for childhood arthritis. These unique features can be well studied with the ultrasound evaluation. Let's come to the ossification centers and let's look at a pictorial view here. So in a child, you have the primary ossification center in the center of the long portion of a long bone, and that is called the primary ossification center. The distal ends of the bone have secondary ossification centers, and the most distal portion is then called the epiphysis. The growth plate is called the physeal plate. It is adjacent to the metaphysis, which then runs into the diaphysis. And look at the difference between an adult bone and a child's bone. So these abnormalities are then, rather, these physiological milestones are then seen when you are doing an ultrasound of a joint, because the distal end of the long bones are articulating with other long bones to make several joints, for example, the elbow joint or the shoulder joint. And so this is another pictorial representation of the distal end of a bone. And here you find the ossification center, which will be white or hyperechoic. You will find an anechoic hyaline cartilage, which can have white vascular channels. And then you have the distal most articular cartilage. So you can then identify the hyaline cartilage, but you cannot very clearly identify where the articular cartilage begins and ends in a growing child. And so when we look at the various long bones in the human body, we note that the secondary ossification centers appear at set times in both girls and boys. And so when we are evaluating the joints, we should not be confused if we see black or anechoic areas, because these are simply the cartilaginous portions of the growing bones. Now, when we do an ultrasound of a joint, we, by tradition, place the proximal area on the left of the screen and the distal area towards the right of the screen. Every joint has a designated position in which it has to be scanned, and we like to use ultrasound probes with certain specifications for different joints, depending upon how big the joint is and how deeply that joint is placed. So we'll just spend 2 minutes on the knee joint, which is most commonly scanned. So this is the longitudinal film of a patient's knee joint, and you can see this is the femur. Adjacent to the femur is what we call the fat pad. Adjacent to the quadriceps tendon is another fat pad. You then have the patella, and it is this blue strip which is then the suprapatellar recess, which is what we are trying to evaluate. And on the ultrasound image, here is the black area, which is the suprapatellar recess that we want to evaluate carefully. And here again, you have the probe placement, and this is the recess that you're looking at, which is an anechoic recess. In a growing child, because the distal end of the femur has cartilage, this is going to appear black, as is this black area around the patella. Now, we should not be confused by all these anechoic areas. These are simply physiological changes taking place in the growing skeleton. What we have to focus on is the recess. So we should know the recesses of all the joints. And you can see here in the ultrasound of a knee, for example, of a 2-year-old child, right up here, this anechoic area belongs to the cartilage of the patella. Here's the ossification center, which is appearing, it is more mature, and here it has taken up an adult form. So we don't have to get confused by anechoic area of the cartilage. What we have to do is to focus on the site of the anatomic recess. And so you can understand the older the child, the bigger the ossification center. Just move this around here to the corner. And here you can see, for example, in the ultrasound of the wrist joint, this is the radius, then you come to the lunate and then the capitate. And here you don't have the ossific center. It's appearing, it's mature, and here it's of an adult variety. So we are not going to get confused, just going to focus on exactly what we are looking for. Similarly, when we are doing an ultrasound of the hand, for example, we should be aware of the various secondary ossification centers of the metacarpus, of the phalanges, and of course of the carpal bones and the distal end of the radius and the ulna. Again, keep in mind that when we are placing a probe on these bones, if the bone is cartilaginous, means its ossification center has not yet appeared, it would again appear black. Why is that important? Because when the joint is diseased, there is fluid which is anechoic, that also appears black. So how do we distinguish one from the other, especially when the fluid is lying on top of cartilaginous bones? We simply do dynamic movement. So we move the wrist joint, and if it is fluid, it's going to move around. Whether if it's cartilage, the shape is going to be retained and remain the same. The second thing we should not be confused about is open physeal plates. So here's a 10-year-old child whose metacarpal bone has not fused, and here's a 15-year-old who has fused. So these are physiological changes which are dynamic in children. Similarly, you take an example of the elbow joint, and here there are many secondary ossification centers, such that when you are scanning these patients in standard scans, you may find, for example, the radial head may not be ossified in a younger patient, but we're not going to get confused because we are focusing here on the recess. We're not going to focus on the bones. And if you know the area to look at, you don't get confused. So to give you an example, and this is the distal end of the humerus and the proximal end of the ulna, which are not fused, but we are looking at the recess here. Normal recess and a recess with fluid. Not getting confused about the blackness, which is not in the area of the recess. And so on, we have the issues as well in the ankle joint, for example. Here a very interesting thing, you're aware that in children who have inflammatory joint disease, there is an increased blood supply to that area. And so there is what we call a physeal maturation. And here you can see you have the appearance of the ossification center of the navicular bone, where that in the normal side, it is not seen. So you can see an asymmetry which can also guide you to a previous or current disease. So here's another example of an ankle joint. So this is the distal end of the tibia, because I told you that the proximal is on the left and the distal on the right. So here's the proximal end of the tibia, and here's the fat which is filling in the joint space of the tibio-talar joint, and this black line here is the cartilage. And here you can see that this patient has got a synovitis on one side and a normal ankle on the other. So always remember to compare one against the other. Here's another example, normal and disease. So as you look at more films, you become more and more confident. When you have inflamed joints, you have increased vascularity, but know that children have much more physiological blood supply, and pathology is only when the Doppler signal is within the joint, that is intra-articular, and intrasynovial means within the synovial recess. So when you see a vertical blood vessel entering the bone. This is a feeding vessel of the open physis, as is this one here and this here. So though you are seeing Doppler signal, this is all physiological. Again, you can see Doppler signal within of the fat in the joint, and as long as it is not inside of the synovial cavity, this is again physiological and should not be confused. There are standard definitions which have been given by the OMERACT organization that defines what the normal physiological areas look like. And further to that, there are also definitions of what is abnormal. Remember that we would always like to scan a joint in two fields, that is in the long axis and the short axis, and be careful about the Doppler signals as well. Now we also have further synovitis scoring, so that not only can we understand abnormal from normal, but we can also grade the degree of abnormality, and this becomes important as we longitudinally follow patients. So visually one can see, but there are also standardized methods of scoring the disease, but we won't go into details about that today. And here you can see that you have small amount of effusion here. Here the effusion is much larger, and these areas are all synovitis. And similarly, you can see for the wrist joint as well. So this is the normal appearance of an immature wrist with the radius, the lunate and the capitate. And here in fact we have the mature hand, which is in fact mine. And here you have a patient with disease with synovitis and a Doppler signal, which is within of the synovial recess. Similarly, here you are seeing normal hip joint, anterior recess and a diseased hip joint, and much more aggressive disease in these pictures. Like I said earlier, we can also go ahead and look at the enthesial sites, and here you have ultrasound evaluation of the enthesis, and this is an area which is currently being studied further in the pediatric population. But suffice it to say that you have a normal attachment of the tendoachilles here, and you can see a marked swelling on the right side for this patient. And then you can also evaluate inflamed tendon sheets. So you can see anechoic and hypoechoic area around this bright normal tendon. And here you can see that this site is totally normal. So again, compare right to left and it gives you more clarity. So here's an interesting young patient who presented with prolonged pyrexia. And when we interrogated the biceps tendon, we noted that there was a tenosynovitis on the right side and it was normal on the left. And this gave us more confidence to state that we are looking at a patient with most likely systemic juvenile idiopathic arthritis. And here's a demonstration of an ankle joint which is swollen in the long axis and also in the short axis. And when you look at this bright white line here, this is what is called the cartilage interface sign, and this separates the articular cartilage from the fluid and is more prominent when patients have disease rather than in normal joints. And these are further pictures of tendons. Now we have got a very interesting further detail coming in about joint evaluation, and this is how we score the severity of disease. So we are able to draw specific lines across joints and see if the inflammation actually crosses the line or not. So here we have a totally normal recess at the wrist joint. Here we have mild disease, you can see. Here the disease is more, and in fact here it is prolific and crossing the line. So this is how we are able to grade the synovitis, and similarly we are able to grade the severity of the Doppler signal as well. So the bottom line really is that we have to know the sonoanatomy, know what is the scan starting position, always use two planes to look at the disease, collaborate with your colleagues, practice and first understand normal from abnormal, And you have to dirty your hands by attending workshops, and every time you go for a workshop, you learn more. So, ladies and gentlemen, I hope I've been able to convince you that ultrasound is integral to pediatric rheumatology. It enhances diagnosis, monitoring, and intervention, but of course, it requires a tremendous amount of hard work, expertise, standardization, and teamwork. Thus far, it's used for joint evaluation, but there are exciting new developments coming up to look, for example, at salivary gland morphology in children with Sjogren's disease, and also to look at the muscle inflammation, for example, in juvenile dermatomyositis. Standard definitions have been laid forward by Euler and Omrat, and I hope I've been able to convince you that ultrasound, in fact, is the pediatric rheumatologist stethoscope. Thank you so much, and I'm happy to answer any questions as and when time is available.
Thank you so much for a wonderful talk. It was truly amazing looking at an ultrasound of a child, and I was wondering when which joints do you exactly do? What is the flow of, or do you do all the joints for a patient who comes for a juvenile idiopathic arthritis?
Well, thank you for that question. So it really depends upon the clinical context of the patient. If we are very clear that particular joints are involved, we may not scan. But if we are unsure, for example, when we see a child with PUO, where we suspect that this is early systemic arthritis, but we are clinically not able to pick up the joint, we would go ahead and do all. Usually, it is more of a directed examination to try to understand the burden of disease and the exact site of involvement as well.
Okay, and you use it for monitoring purposes as well to see if the disease is responding to the conventional DMARDs.
Yeah, we certainly do that, and we would specifically do that as we begin to wean a biologic agent or a conventional DMARD for the patient, and certainly as we plan to stop the medication fully. Because you're aware that a clinical examination is not as sensitive as the ultrasound exam, and specifically persistent Doppler signals in a child who appears to be clinically inactive and is then coming off medication would suggest that that child is at high risk of flare.
Thank you, Dr. Sujata. I'm Dr. Taira Parveen. So I'm a little bit newer in the musculoskeletal ultrasound. I recently started learning the adult musculoskeletal ultrasound, and looking at your presentation, it's pretty challenging to diagnose. I could see the pictures you were showing. So I just wanted to know, just like in adults, they have got a lot of scoring system so that there is uniformity in the reporting and diagnosing. Do we have such reporting system in peds as well?
Yes, we have two scoring systems. We have a scoring system from the OMERAT, and we also have a scoring system from the US, from the CARA group, and that is currently called the musical scoring system. So this is still work in progress for children to have standardized scoring for sure.
Yeah, thank you so much. So with this, Dr. Sumaira told us that you have to join.
I want to thank
else.
Sujata so much for taking the time out. We were really looking forward to hosting you, particularly this has been something I've been wanting to do for many years in Lahore, you know that. So hopefully very soon, inshallah. And the virtual shield and memento I'm handing over to you, and please accept with all of our regards. Huh?
Thank you so much, Sumaira. It was such a pleasure to join in.
Yes.
Thank you so much.
Thank you. Thank you.
We're pleased to welcome back Dr. Tash on the stage, who will now be presenting on childhood scleroderma. Please welcome him back on the stage.
So I try to preserve the time, but then let's ask Dr. Saira, should I cancel it?
I've been waiting for the scleroderma talk since the morning.
All right, let's get on. I will introduce another rare disease, but you can change a lot in terms of the patient outcome. Okay, juvenile scleroderma divided into localized form and systemic form, and then we know. Since I was a fellow actually 30 or 40 years ago that localized scleroderma as a pediatric rheumatologist or even adult, if you want to look at scleroderma in kids, you see the localized form 9 times compared to one of the systemic sclerosis or scleroderma like adult, the systemic form. So ratio is 9:1 in terms of the prevalence. So because it's more common, and you guys still alert, then I go with localized first because this is the disease that you can change their future a lot if you treat early. Okay, there are many classifications, but I don't want you to remember. I want you to remember this one. We classify according to the depth of the skin involvement, although there are extra cutaneous manifestation that I will touch back on. But then the disease, majority of them, I'm not saying 100%, most of them start from the skin. So you will see the skin change. And actually the change on the skin in terms of the activity of the disease or damage, actually reflective in each one. So limited types is a type that is quite shallow. It never go beyond subcutaneous tissue. Okay, I will have picture for you there. So plaque morphea is more common in adult. Okay, so generalized type, this one is actually, if you talk about generalized morphea, meaning you have plaque morphea, but it's bigger in size and 4 or more of the numbers. And it's usually everywhere, including the trunk and the extremities. And this is more common seen in adult. Disabling pansclerotic morphea, this one, if you look at the patient sitting in front of you, you think that he or she may have systemic sclerosis, but not be confused. And this one go all the way to from the skin to the bone and very disabled, this one, if you treat late. Okay, linear subtypes, like linear scleroderma, this is the linear type that is like a band that you see more in children. In many series of the localized scleroderma, this occupied about 40 to 50%. Okay, and then you have engroup the subramine, the band happen on your forehead, including the scalp in many patients. And then you have another one. This one is the one that is we see not that uncommon in Singapore and in other countries called Perry-Romberg syndrome. This one has very little inflammation, but it's go all the way to the bone. So you will have, as the name said, progressive facial hemiatrophy. One side of the face goes away. And that one can be delayed if you treat early. And the last one would be deep type, meaning the skin more or less is a spillover from the underlying skin or subcutaneous tissue inflammation. Oh, I thought my time is up. Yeah, too fast. Okay, so this one is the one that treatment outcome is quite good. Actually, I will show you the picture, then you know what I'm talking about. But just remember, just try to get a grip of it, that we classify according to the layer of the skin involvement, why the treatment go like that as well. I forget to mention superficial morphea. Rheumatologists, we usually use the term localized scleroderma. Dermatologists usually use the term morphea, but it's interchangeable. This one, atrophoderma, you have to see the picture. It never go to subcutaneous tissue. It just go to the deeper layer of the dermis. Okay, so estimate is about almost 10 times of the systemic sclerosis there. Okay, up to 3 cases per 100K, and then 30% happen in childhood. Okay, female is more often than male, like any other disease. And the disease we see more in Caucasian, up to 82%. Okay, but we see not uncommon in Asia. Okay, so this is just to tell you how rare it is or how common it is. 17 times more than JIA. Less common compared to JIA, and 3 times less common compared to lupus. Okay, so off and on you may see them. But I guess that in Pakistan or in South India, if it's not really give you pain or disability, the patient may not come to see you. Or if they think it need to be seen, maybe end up with the dermatologist who does not who should not be the one who treat, if anything, below the dermis. Okay, because your cream will not penetrate more than 0.8 millimeter from your skin. So topical will not work. That's why. Now this is just to compare adult and pediatrics because we have some adult here. Okay, circumscribed morphea or plaque morphea more common in adult. Okay, linear scleroderma more common in kids, and I mentioned 50% is you're gonna see them. And generalized morphea over here is more common than adult as well. Now, the more generalized, the more autoimmune or inflammatory marker, whatever kinds that you want to see in the serum will be present together with the biopsy on the skin. Okay, and if I directly tell you, if you have a lot of inflammation, treatment will be better. I mean, in terms of the response to the treatment. Okay, and mixed form, we do see some. Okay, and this is just to start with the plaque morphea. The lesion is like a prototype of the localized scleroderma. Activity usually at the edge. The center is the old one. Okay, so anytime when you see the red shade, it means it's active. Inflammation is still there. Okay, and then when it gets longer, it becomes atrophic. Then it becomes hypopigment or hyperpigment. Like this patient has some hyperpigment. But the border almost always, if you want to assess for activity, is at the border. Okay, and this is all these are quite active except for this one and this one. You see there's no red shade at the border anymore. So when you see patient like this, you don't need to treat because it's nothing for you to treat. It's too late already. Okay, this is the one that you want to treat. Sometimes the inflammatory phase is not that obvious, especially the dark skin. Then you have to trust their history of the enlargement of the existing lesion or more numbers increase. Like instead of one, you pop another one. Those are the activity parameter as well. Okay. And then this is a subcutaneous. It's called deep morphea. So the skin is quite purple there. And this is the significant inflammatory shade of redness. We call violaceous. And this one has a subcutaneous inflammation there. This one is generalized morphea. You see each one of them bigger than 3 centimeters. And then you need to be more than 2 anatomical size. Treatment is not that different. It just tells you that you need something that cover in widespread area. Okay, so topical may not be the fan of yours to use. Okay, and this is a typical one that they come to see you. Linear scleroderma, as I said, is go all the way to the bone. And this one obviously has leg length discrepancy already. Okay, this one many years already. One is contract like this, it's hard to recover. Okay. Now, in some patients, if you don't know whether it's still active or not, especially in the linear form, and the history, the parent tell you that it's still getting bigger. To me, I still think that you should treat. Okay, in order to the maximum that you get is you don't get worsening. Okay, if the patient responds to treatment, compared to you don't treat, and then if it get even further, then it will be very bad because all that you see, fibrosis in medicine we still cannot reverse. What is called to fibrosis is there. All this pigmentation or atrophy of the skin or subcutaneous tissue, when you see it, it's still gonna be there. Okay, it won't change. The change is you just prevent the extension or enlargement of the existing lesion so it won't go across your joint line and cause contracture like seismic sclerosis. Even band line like this, it can contracture your joint. This patient has 50% range of motion on the tibial joint, and then MTP here actually no motion at all. And she also has plaque morphea over here that is still active. And that's the whole reason that I need to treat. And this patient just within a month that I see. Okay, so her disease is not that bad, but the old one already bowed down over here, so I cannot change anything. That's the counseling that you need to tell the parent. Existing lesion, one is fibrosis. You cannot do anything. What you can do is minimize the extension, and hopefully it's not getting worse. And this one has a tophoderma, as I said. When you biopsy, this is a type that has less inflammation, but the disease does not go deep. It go to your dermis, reticular layer only. So you see like the skin has a stepping. You see the stepping. This is the severe degree of dermal atrophy. Okay, and majority of the patient has hyperpigmentation. and does not have anything involved deeper. And this is not common at all. It's called cathete. Cathete means small dot of the morphea. If you look carefully, it does not look like psoriasis. It's not. Okay. Okay, this is Perry Romberg. Okay, this patient I treat very young, and this is when he first present. I don't have the comparison. He still look the same. And this one many years already, so you see that there's a distortion of the face already, and this I cannot change it. What I can help is not getting further. So we involve the maxillofacial surgeon or your simple core dentist to do panoramic X-ray and measure the growth of the bone. That's the only thing that you can do to assess whether your treatment is okay or not. One is small, it's still small, but if it still keep growing, this right side, unaffected side, gain by 1 millimeter, I expect this one gain 1 millimeter, even though the starting point is low. And that called successful treatment already. Then at least they don't need to do major surgery to plaster the bone, to make the bone thicker in order to make her beautiful again. Okay, and this is the one. You see, the whole face is already gone, and something like this come to you. If it's not progressed, you don't need to treat. This one has the mixed form. You see the band here. They have two bands. One is here, another one is here called encroop the sabre. And then you have the whole side is small as well. 40% of the face and scalp involvement has the mixed form. And this one actually 7 years. That delay, and see the dermatologist, and they didn't even pick it up. The whole size is smaller. Okay, so this is another one. That is quite. This is from Pittsburgh. One of my patients when I was there. So this is just encroop the sabre. Yep. This is pansclerotic morphea. If you look, it looks like systemic sclerosis, but this is not, because it does not go beyond that, and there is no systemic involvement. Okay, and it usually spare the fingers and the toes. Okay, so this is just to convince you that localized scleroderma is an autoimmune disease by the evidence. Or I just mentioned about the dermis. Okay, so you have two layers of the dermis. This is epidermis, and then you have papillary dermis, where you have a lot of nerve ending and capillaries. So this is like nurturing a layers, very thin. And then you go to the deeper one, where you see a lot of matrix collagen deposit here. And this is actually, the function is to stabilize, is the strength of the skin. Anytime when you have the disease go to the reticular dermis, the patient usually have some disability, some contracture, some pain even. Okay. Then, so when we biopsy, we have start from perivascular infiltrate, also all these eccrine gland infiltration, lymphocyte more than plasma cell. Sometimes we see eosinophil. Regardless of the subtype, the bottom mean the reticular layer heavy or everywhere involved is associated with increased risk of pain and functional limitation, as I mentioned. Sclerosis usually happen after you have inflammation. So this is the one that you can stop. But when it go here, you cannot stop. So we try to prevent further expansion or damage. NA positivity is 30 to 70% compared to systemic sclerosis, up to 80 to 95%. Okay, and we do see some scleroderma associated or specific antibodies, but it has nothing to do with the subtypes or anything. Okay, rheumatoid factor positive up to 15 to 30%, and this related to the arthritis. Okay, when you look at the blood, the Th1 and some of the Th17 signature is in the blood. I mentioned CXCL9, CXCL10, and these two actually may become the biomarkers. And this is like I mentioned before, same as galactin-9 or CXCL10 in JDM that we mentioned before. Okay, so when you have in the acute phase, you are more of the Th1 and Th17, but when you get into the fibrotic phase, then it will be more Th2. Okay, in the skin we also see the Th1 signature. This is interferon related chemokines. And in the skin, for some reason, we don't see anything deal with the TH17. So TH17 targeted is still not in localized scleroderma. But then for the interferon, you may be able to use in the recalcitrant disease. Extracutaneous involvement, this is a meta-analysis anyway. About 3,000, over almost 4,000 children in this literature review. About 30% will have extracutaneous manifestation, and these are the top three winners. Musculoskeletal start from joint contracture all the way to the arthritis in 25%. Neuro usually include the Sabre or the Perry-Romberg, the one that go be above the necks, usually have neuro involvement up to 40% actually. So if you lump it together, it's about 10%. And then odontostomatological, meaning your mouth opening, your facial bone below here, get involvement is about 8%, less than 10%. Okay, and this is more of the Perry-Romberg. Okay, musculoskeletal, as I said, arthralgia is 1/3. If you count joint contracture, then it's become more. Muscle atrophy, usually secondary to not using. Okay, myositis quite rare. Okay, neuro, if you lump headache, then that's probably get to this. But then when you do the MRI, majority of them even asymptomatic, you will see some white matter change. And then we do see off and on convulsion or seizure. And with treatment, it also goes away. Okay. And then talk about the face. I told you already, the Perry-Romberg is the one that may go all the way to your, even the tongue hypertrophy and the maxilla and the mandible bone actually smaller. And that's been reported quite often, almost up to 1/3 of the patient. And this is unusual involvement, can go all the way to respiratory system, renal, and these are quite rare. Okay, ongoing or concurrent autoimmune disease, thyroid seems to be the common one. Okay, outcome measures. There are many equipment that try to replace the clinical examination, and up to at this moment, I get into the research since I was in Pittsburgh many years ago, the year 2002 until today, 2025. None of the imaging study become the outcome measure that we use to measure the patient activity in a clinic or in clinical trial. We still based on what we developed many years ago, clinical assessment. And then this is just a pro and con, and then the sensitivity, specificity. As I mentioned, the one that I want you to pay attention to would be the MRI. Because in the deep form, you may use MRI to see whether fasciitis is still there or not, or subcutaneous inflammation still there or not. Because sometimes it's hard to tell from the skin change, because skin will be normal. Okay, so that's the one, and this one obviously with contrast. Okay, as I mentioned to you, we treat only active disease. The damage, we cannot do anything. Okay, so this is the one that will stop that one further. And then the key for activity is the skin redness or the enlargement of the existing lesion or the new number. Okay, and also the skin thickness at the border called skin induration. Induration means it's reversible. It can go away because of the skin edema. Okay, for the damage, we look for the dermal atrophy, we look for the subcutaneous atrophy, we look for the color change of the skin called dyspigmentation in terms of the lighter or darker or skin thickness at the middle of the lesion. And this is when we usually see the patient over here. You already have some activity which may be on the way down, but then you already have damage that you can identify. Okay, so it's called localized scleroderma cutaneous assessment tool because we look at the cutaneous and subcutaneous tissue only. As I said, this is actually like systemic sclerosis, where you look at the skin thickness, and then that varies according to the disease activity, especially in the diffuse cutaneous form. So we look at the skin and subcu. As I said, we use 18 anatomical sites that I will show later. And this requires minimal training because skin thickness, we use the same as systemic sclerosis, modified Rodnan skin score. and then I'll go through that in 10 minutes. And then you also use physician global assessment of disease activity, mean something that can be reversible, and then damage, mean it's not reversible. And this alone will include extracutaneous involvement. Majority of the time, extracutaneous involvement is not the things that make you treat. For example, a joint contracture, because it's secondary to skin thickness. That's why. So, okay. And then this is 18 anatomical site. Scalp and face, neck, chest, abdomen, upper back, lower back, arm, forearm, hand, thigh, leg, foot, right and left. You do the math. This is 18. And then you do just simple math, 0 to 3. Okay. And this has been validated 20 years ago. Okay, it fulfills every single reliability and validity test. And then you have PGA here, and then you have damage there. And when you talk about activity, we call skin activity index. And then damage is called damage index. So the lost cat is actually involved both activity and damage. Okay. Okay. So that's what I said. Now we go one by one. Erythema. So when I make this skin score that we did the year 2000, something I forgot already. So it's quite clear cut. 0 mean normal. Okay. Pink mean here. This is number 1. So mild mean pink. As soon as you can see, appreciate the redness, then it's already 2. The moment that you see the violations of the purple shade, light blues, light, then you number 3. I don't think you can miss that because it's clear pink, red, and violations. Now you look at the skin thickness. This is need training a little, okay? Like systemic sclerosis. 0 mean normal. You can make wrinkle. You can make a fold. This is called pinch exam. You pinch and then you still can see the skin wrinkle there. 1 mean you can pinch, but you have a hard time already, and then you still see the wrinkle. But it's harder than here, normal. And then moderate mean you can pinch, but you have a hard time, and then you have no wrinkle anymore. 3 mean you cannot even move, even with 2 fingers like this. It's called bow down. And this is clearly, this needs skill anyway. Okay? And then you go to the dermal atrophy. The moment that you see the shininess of the skin, you lose the epidermis already. That's why the light reflects back to your eye right away. And this is mild. The moment you see visible vein is moderate or 2. The moment that you see the crypt drop, meaning you lost a good layer of the dermis, then it's called number 3. So this is also clear cut to you. Okay, and the subcutaneous atrophy same. Normal mean same. Flattening mean flat. This is 1. Concave mean 2. Bow down here, no subcu mean 3. So it's quite black and white here. And then this pigmentation a little bit need training. And you compare to the patient shade, mild, moderate, severe. Severe mean no pigmentation. This is 3. Or super dark, like the mole here. Okay. All right. And then this is just example that you grade. You will pick the worst of that region. In region, you may have more than 1, but each parameter, each domain, you pick the worst one because that's one that drives your activity score. Okay, as I said, we published in the year 2008. Now we already know that how the skin. That's how I can tell you how the skin evolved after your treatment. Our colleagues, Texas Southwestern, Heidi Jacoby, actually a dermatologist that adopted this in 2008 we talked, and then she already has the good 10 years data to tell the natural history. Okay, and this is coming from her cohort of 500 patients, but because she looked at the natural history, then at least 2 years. Okay, even some of them for the damage is 5 years even, so it's quite accurate. Okay, so I just gonna go to this real fast. So this, I look at the timing and the rate of the recurrent. Mean follow-up here is about 4 years. This is proportion of the patient. If you have generalized, you recur 43% compared to 21% in linear scleroderma. Keep in mind that this group use systemic treatment with methotrexate at least 2 to 3 years, but this one use UVA therapy, so it's about 3 to 4 months. So when you stop, half of them recur. Okay, and obviously methotrexate get less recurrent compared to phototherapy, and children get less recurrent compared to the adult. Okay, because children we usually more aggressive and we treat, and then this is what we said here. Okay, 29% recur at the median of about 20 months. Remember this number. A third recur at the 20 months. Okay, so this is change in the disease activity and damage. This used more than 5 years. Okay, so when you gonna, if your disease after you get inactive disease or stop treatment gonna recur, 82% of them will recur at the same existing or the previous plaque or the previous lesion. Okay, and the disease activity actually lower compared to your first present. So this is a little bit of the good news. Okay, for the damage, actually quite stable. Okay, so what we know is this slide, 75% of them will have more than 50% improvement in terms of the skin thickness. Whether they do it or not, it will be softer. But the skin atrophy and the subcutaneous atrophy actually can get worse. Okay, so that is what I said before. It won't go away. And upper extremity is actually better than lower extremities. So long-term outcome here, as I mentioned, this 30%, and it's about 20 months that it will recur within 2 years. That's when you stop the treatment, you can tell your patient. And this comes from the big cohort from the West. Predictor of flare, older age at onset, linear on the limbs, delayed treatment, NA positive. And then another one that I forget to put, 2 shots for the treatment. Okay. And then I'm not going to mention this because it's not coming to use yet, because this group is actually our group that start to take the extracutaneous and craniofacial complication in there. As I said, many of them does not affect the treatment. Okay, it's mainly of the skin. So I'm just going to jump real fast because the form is like this, and then they are waiting there. So in a busy clinic, these take about half an hour to score it. So even I don't do it. Okay, and then the group also, this is my ex-fellow, do the quality of life. So this is just for you to know that it's coming. We are under the validation process. And then it look at skin sensation, look at the disfiguring and musculoskeletal involvement, look at the image and social change, and then the subscale, look at the medication side effect. Okay, and the treatment, I just gonna go real quick. Treat to target. You have to have a target. Activity, use lossy, the severity score, damage score is also to assess the damage. Okay. MRI you will use for every single one that has the lesion on the face and the head. As I quote the number to you, 40 to 50%, you may see something in the brain, and you may or may not need to treat. Okay. And then together, you have once a year, the doctor, the ophthalmologist need to see, especially the one that involve face and the scalp. Okay. And then methotrexate, subcutaneous high dose at 1 milligram per kilo, still our way to go. The steroid, you can give 2 per kilo and then wean it down. Or you can give pulse if the patient worry about Cushing. You can admit them for monthly pulse for the first 3 months when MTX is start to kick in. That is okay. Outcome is not different. Okay. And then if they cannot tolerate that, then MMF. The data is less, but you reserve it for second line drugs. Okay. And after that, if MMF you actually resist or still have problem, then you have to go to the experimental, and biologic is the way to go. Okay. So I'm talking about the 2 biologics. One is abatacept. 55% of them will use tocilizumab or another 50, and outcome is quite okay. Okay, but this is quite expensive for you. Okay, majority of the time I don't need actually. Methotrexate stop everything. Okay, and this is just to show you when you use a Euro protocol, 15 milligram per meter square, and some of them are even oral, recurrent rate is quite high compared to the MTX sub-Q maximum dose at 25 milligram with concurrent steroid. Okay, and this is the treatment. You see from this contracture all the way to grade, and this is the deep morphia. This and this and this normal. So this is a good treatment for you to do. And this is the one that is quite late, but it still help you because, as I said, once the involvement is not It's not further going down than your contracture, because when the skin get fibrosis, it's like rubber band pull it together. So this one do not need to be like this anymore. You see, it gives you a scoliosis from the skin pulling together, and that actually get better. Obviously, the color of it over here won't get anywhere. You're still gonna see it, but functionally, at least she can walk normal. Okay. Now I go to systemic sclerosis, only 10 minutes. That should be enough. I go quite quick. It's even more rare. Sometimes you may not see it at all. Okay, female to male 4:1. And then if you look at younger than 16 years old, it's less than 5%. If you cut off at 18 years old, it's less than 9%, something like that. And then if you look at the whole cohort of the systemic sclerosis, kids is only 10 to 20%. And then I just gonna relay to you that early involvement is still Th1, Th17. After that is more Th2. Same thing with the localized scleroderma. Okay. Yeah, that's I say already. Now, so diagnosis is adopt from the adult, but we are more relaxed because majority of the manifestation you may not see in adult. So every single one has to have skin thickness, and then minor criteria, at least 2 of these. Okay, and then sensitivity is over here. Okay, and then this I just want to talk about the very early scleroderma. Adult, they start to recognize. We do the same thing. If the patient comes with renal phenomenon, 2 things you want to do in order to make sure that that is either primary or secondary renal phenomenon or renal syndrome. If it's primary, meaning it's just not going to give you any tissue loss or auto amputation, we call renal disease. You will not have capillaries, and then you will not have scleroderma associated antibodies. When you have one of those, the risk is higher. And this data come from adults that they look at. If you have 2 of them together, the risk is very high. So this is adult from the adult. Okay. Now, so I look at the recent data, this published not long ago. The Japan actually is the endemic area for systemic sclerosis. The manifestation is not different than others report. So I just gonna summarize here from the juvenile form and the adult onset. What are the difference? Okay, we have overlap syndrome more than that. In some series, when I was in Pittsburgh, 30% of the patient is overlap. Okay, we have 3 forms: diffuse cutaneous, same limited cutaneous, or the crest syndrome, but overlap there. We have a third, and a third there. Okay, and that reflect in the antibodies. PMSCL is related to the overlap syndrome, where you have myositis and some skin thickness. Okay, and another thing, renal crisis in kids is unheard of compared to the adult. Okay, and that lead to hypertension. I don't see at all. Okay, and that could be explained partly by the low incidence or low prevalence of your RNA polymerase 3. And you already know that this is actually related to the renal crisis in adults. So the use of steroid in kids, feel free to use. Okay, and then tendon friction rub, I hardly see in kids. It usually happen in adult. Okay, and anti-centromere also old people, old adult, even kids we usually don't see. Okay, U1-INP go with the overlap syndrome, so we see more than adult. So this is just reflect. This is another disease that autoantibodies also give you the clue. And I want you to read the adult. It's the same. Okay. So, so this is just the manifestation. Every single manifestation frequency we have less than adult. But if one of the systemic sclerosis patient come to see you, I want you to expect, number 1, skin thickness, almost 3/4 or actually some series is up to 90%. Okay, renal phenomenon also seen. Even you live in the warm country like Singapore or Thailand, you still can get renal phenomenon. Okay, and then you almost always see the digital pitting. Okay, if not infarct even. And then abnormal nail folds, we have less than adult. Okay. Then yeah, so other than that, we have less than adult. Even the major organ here, we hardly see. So the kid that come to see you mainly is for the skin thickness and for the renal phenomenal control most of the time. Okay. Now, somewhat 10% of the adult, in adult cohort, you will see the systemic sclerosis, scleroderma, meaning they have everything like systemic sclerosis, but they spare the skin, meaning this patient does not have skin thickness. Okay, in adult is about 10%. Okay, I get consult quite off and on. Okay, because they usually come in with ILD, interstitial lung disease. Okay, actually most of the time. So this compared to the adult cohort in the same center, and then we have less female compared to the adult form, and the disease delay in diagnosis is quite longer. You can see, okay, and the severe outcome we actually have more. Okay, and this go, yeah. Anti-centromere, as I mentioned, even in senior scleroderma, you see less compared to adult 70%. And then respiratory symptom is the majority, okay? And then cardiac is another one. And these are the two most common cause of death in this population. And yeah, so they die, 6 of them die, meaning a third of them die. So this seem to be a little bit more severe than adult, which I do not know whether the delay in diagnosis and introduction of the treatment has anything to do with it or not. And this is a patient from Pittsburgh. There, you usually see this more common. You see that you lost one segment over here. This is PIP, this is DIP. The tip of the finger is gone. Okay, this is actually you see in the childhood onset quite often compared to the adult. Okay, and then this is the patient that we, whatever you see in adult, you can see. And someone asked me about calcinosis. Kids, when you delay, you see that also. And you also see mat-like telangiectasia. And this girl actually in the virtual of losing the toes here because it's almost black there. And ILD we also see in some patients, especially with the topoisomerase 1 or ACL70. And this girl also lose one autoimputation. You don't see the distal pharynx here. And this is like the slide before. You see only in childhood onset. Okay. And then activity or severity we adopt from the adult. So you can look at that. This is 9 parameters there. The only thing different is the muscle. We use CMAS. Compared to the adult use MMT. Okay, everything else more or less adopt from the adult. Now I go to the treatment. This should be close to done. Okay, so the treatment is more or less like adult. Okay, if you have isolated Raynaud's, you want to look at the nephrocapillaries and also send the Scleroderma specific antibodies, and everything you treat according to the organs involvement like the adult. As I said, we always start with systemic corticosteroid plus conventional DMARD. Okay, as long as you don't have major organ like heart and the lung, you don't use cyclophosphamide, you still use methotrexate. And sub-Q, I'm not gonna push it because inject into the thick skin is very painful. Okay, if this is not working like adult, next one you do MMF, and that help with the skin progression. But in pulmonary involvement or heart involvement, you must use cyclophosphamide. Raynaud phenomenon, many patients like this morning, majority of the time, you treat the inflammatory part is fine, but the supportive treatment is very important. Okay, you have to open up this by giving vasodilators, start from calcium channel blocker all the way to prostacyclin like Iloprost here, in order to prevent further loss of the tissue, because the next one would be the bone that they will lose. Okay, biological agent we adopt from the adult as well. Okay, so this is what I look. In a stable disease, use symptomatic drug. You must consider Raynaud phenomenon, treat it well. Otherwise, you will run into many problems. Calcinosis, either from poor circulation, you have to improve that and give whatever that you can give. People start with colchicine, some with diltiazem, some with bisphosphonate. It's exactly like JDM protocol. On my hand, I actually like alendronate, and I see some success there. Okay, and this is just what I mentioned before. Okay, the outcome, the red one is pediatric and the adult. You look at the time, that is from Pittsburgh. This is our own series from the registry, almost 3,000, and kids we have only 100. Kids prognosis, survival rate is much better than adult by 10% roughly. Okay, the young adult one, I didn't show you. It probably, but around the world is the same. Kids are quite good. Part of it because they don't have major organs. Okay, and then this is just for adult. You probably know already the childhood onset and the young adult, which is younger than 40 years old. The mortality rate is the same until 10 years. Then you branch out. The young adult die faster. Okay, that's just that. Okay, this is just my summary already. I always have you compare. Okay, so diagnostic criteria is a little different because we don't have major organs much. And then I said localized form is more than systemic form, and then more overlap features. And we have all these antibodies. Okay, we have very little RNA polymerase 3, so renal crisis is unheard of. So you can use steroid. Centromere we also have less, so you don't see much of the CREST syndrome kind of limited cutaneous manifestation. Overall outcome quite good. Okay, and then localized scleroderma, this is just to tell you, when you want to use methotrexate, please use high dose sub-Q, and then early on, and then you maintain it. Nowadays, I maintain after inactive disease, mean the parent tell you it's not getting big, by your measurement it's not getting big, then you extend 12 to 24 months before you wean down. So total usually about 3 years. And you know that the moment that you stop, within 20 months, 50% will flare. Okay, 30% will flare, I'm sorry, at the median time of 20 months roughly. Okay, so nowadays our protocol is about 3 years. Okay, and because I mentioned the scoring system, so I have to acknowledge my colleagues in the US and my 2 kids. And then this is I showed their picture. This is a clinical team, and this is a translational team that we have in Singapore that I need to thank. Otherwise, we have no data. Okay, and thank you for your attention. I overtime a little.
Thank you so much, Tash. That was an excellent talk. I just would want to ask you about systemic steroids. You mentioned that you give high dose pulse steroids for scleroderma patient, systemic sclerosis patient as well. In adults, we know we are always scared of invoking the renal crisis. So have you ever noticed that in juvenile patients?
Since I'm here, I just use this microphone. I just kick him out. So for the systemic sclerosis, depend on how urgent that you want. I never need to go to the pulse unless you have cardiopulmonary. I get consult from Thailand. Usually senior scleroderma, 3 girls at one time from the northeast with the ILD very bad, need oxygen. Now they go to university. So the point here is you use steroid high dose when you need it, and then you need to salvage the organ and decrease mortality. At the same time, your methotrexate hasn't kicked in for the next 2 to 3 months. Steroid is the only one. Compared to adult, you are more skeptical about that because of especially the one who has RNA polymerase 3. And this knowledge we know since we report since 2006. Go ahead and use it. If you need to use PAL, fine, but you should have a reason to use. But what I'm saying is the first 3 months is still steroid, nothing else. I never seen one. Yeah.
I've got another question, Dr. Tash. We wouldn't let you get down from the stage. So I'm here.
Oh,
Okay.
sorry.
So I'm Dr. Taira.
Yep.
My question is that you have given the scoring or the staging mild, moderate, and all that skin involvement.
Is it for systemic form or for localized form?
I'm talking about localized.
Localized,
Localized,
okay.
yes. But because we are colored people, we might not show that much pinkish or that much reddish thing. So how do we differentiate what we are talking about?
Yeah. So then I see this morning when they are dark, they're really dark. Many times you still can see erythema. Like when they have mosquito bite, they get erythema. You still can see, but if that's hard for you, then you need to measure the size if they have plaque morphia. Otherwise, you have to use your anatomical bone. For example, or at this moment, he start with all the way from the toes at the MTP joint, all the way the band continuously go to the top or the upper border of your patella when the patient is on the supine position. That is the way. I usually don't tell you to use any measurement because my colleagues in Italy has a lot of money. So he just buy the Tegaderm, like big one. I don't know how much it costs here, and put on the patient's skin and draw and put in a chart. That one is taking time and is still not as accurate. Okay, but then you have to do what I said. Use the area on the anatomy, and say there. So normally when in my clinic, we have the skin map, actually from the front and from the back. And then every single bony landmark is in there. And then when you want to draw, you tick the border here. For example, upper chest from the xiphoid process up. So you count the nipple area. If it go to the nipple or past the nipple, if it start from the middle here. You have to use this kind of thing to your benefit. That's only way. Another one is if the parents are concerned, they can tell you that is go or not because they look at them every day.
Thank you so much.
Thank you to our speakers and the audience for this engaging exchange.
I would now request our worthy chairs and Professor Dr. Shahida Khwaja, renowned anesthesiologist and CEO of the National Hospital Lahore, Professor Dr. Nigat Mir Ahmed, Patron-in-Chief, and Professor Dr. Somaira Farman Raja, Chair of the Scientific Program, to please come on the stage and present the awards to our amazing keynote speakers.
Dr. Tash Arkachaisri.
Dr. Elizabeth Ang, please come on the stage and receive your award.
Dr. T. Kai Liang.
I now request our worthy chairs to please receive their awards. Dr. Saira Elaine Han. Dr. Tahira Parveen.
We request our chief guest, Dr. Shahida Khwaja, to receive her token of appreciation. We would like for Dr. Shaida to please say a few words to the audience.
Dear all, very good evening and Assalamu alaikum. I'm honestly honored to be here among the galaxy of shining stars of rheumatology and other disciplines of medicine. I'm so happy that I happen to be here as part of this Congress. You know, the foundations of the Society of Rheumatology belongs to the ones who started this discipline. Professor Nighat Mir has got such a, I should say, charismatic personality that she tangled Professor Sumaira Raja from Islamabad to come and join her, followed by Professor Ahmed, and then all the youngsters to follow. They started this specialty, I think, about 2.5 decades ago, or maybe even more. And the amount of effort they put into that, you can't imagine. I congratulate them for starting this difficult thing in a way, because when you are introducing a new specialty, new discipline, it becomes very difficult to make people understand, because earlier than that, everybody thought that it's the general physician. I'm sorry, with due apologies to all the GPs from my side, because they used to think that they are all in all. They are going to take care of everything, and it was very difficult for them to accept that there are super specializations who have to take over. I really congratulate them from the depth of my heart for organizing this wonderful program, wonderful Congress. This Congress does not mean just interacting with each other. You learn from each other, from your peers, from the seniors, and everybody around. You do networking. Then among the social things, you meet each other, you greet each other, and then you have good entertainment in the form of good food. And along with the good food, there's some part of music as well. So many congratulations to the organizers, led by my very, very dear friends. And I hope, inshallah, they'll continue with that and they'll pass on these good traditions to the younger lot who have joined them. Thank you so much, and congratulations once all. Thank you.
That brings us to the end of our session. Thank you for your presence and participation. On behalf of PSR, we'd like to extend the invitation of tonight's lavish inaugural dinner and beautiful cultural event. We request all participants to join us in the grand ballroom at 7:45 sharp. Wishing you all a pleasant evening ahead. Thank you so much.